Let's continue. All right, so talk about self-sufficiency in growth signals. In this case, we are going to start with talking about the RAS, actually signaling protein. RAS is part of a family of signaling protein that simply actually sends signals into the cell. In this case, for the proliferation for cellular division. And the RAS protein is usually kept in an inactive form on the inner surface of the membrane of the cell, as you can see here. It is kept in an inactive form through two mechanisms. One of them is a bridging protein that tie the RAS to it, thus keeping it inactive. The second actually way for it to be kept inactive is through binding the GDP, the guanine diphosphate. What happens actually is that the other connection of the bridging protein is with the growth factor receptor. So when there is a ligand that will come and joins this growth factor receptor, you're going to be seeing a signal that is going to go through this receptor into the cytosol that is going to result in a conformational change of this bridging protein that is going to detach from the RAS. That's one. Two, the RAS is going to be coupled up with the GTP, with the guanine triphosphate. Now, this coupling up with the guanine triphosphate is going to activate the RAS. And when the RAS is activated transiently, it is going to be sending signals that is going to go through two molecular pathways, the RAF-MAPK pathway and the PI3K pathway. Both of these pathways are going to converge on the nucleus and put the nucleus in a transcription overdrive, okay? But it is going to happen very transiently. Why? Because the GTP itself that binds the RAS and activates it has what you call a GTPase activity. So the GTPase is going to cleave the GTP from the RAS, and as a result of that, the RAS is going to be rendered inactive again, and the bridging protein is going to come in and is going to fix it in place again in its inactive form, okay? Now, what's going to happen if you have actually a mutation that is going to result in a permanent activation of the RAS? This mutation is going to be either in the GTP binding pocket or the enzymatic region essential for GTP hydrolysis. So the end result is going to be that the GTP will not be coupled out or decoupled from the RAS, resulting in, again, theoretical permanent activation of the RAS. And the result of that is going to be permanent firing into these two pathways into the nucleus, making the cell go into a hyperdrive of division, giving rise to many divisions of that same cell, which is the definition of tumor, right? So that's what you see with a mutation affecting, the RAS gene. Now, allow me to tell you that anything that is going to be, these are two, these pathways that you see here. Just one second. So these two pathways that you see here, you see here are actually very simplified. There are far more components of these pathways than what you see here. Any kind of, again, activating mutations of the components of these pathways is going to result exactly in the same, kind of effect a permanently active RAS will do on the nucleus, because they will keep firing into the nucleus in a permanent way, putting the cell in a hyperdrive of division again. Okay, is that understood? Does that make sense? This is really the essence of this slide. I know it looks scary. Anything regarding genetics, is probably a little bit complicated, but I think this way, you have gotten the hang of it. Okay, this is number one. All right, now talking about the cell cycle. So the cell cycle is a very tightly controlled process. It is tightly controlled because actually the cell cycle is kept in a lockdown. It's kept in a lockdown as a result of the presence, as a result of the effect of the retinoblastoma gene, which means the checkpoints going from the G1 phase of the cell cycle into the S phase, okay? And why is the cell cycle actually kept in a lockdown? It is kept in a lockdown to slow that cell cycle, to make sure that the genetic material that is going to enter, the S phase is going to be an intact kind of genetic material to ensure that there are no mutations. There is, a second checkpoint that is going from the G2 into the M to ensure that, again, the genetic material that is going into the offspring, cells is going to be intact as well. Now, retinoblastoma gene is not there alone. Retinoblastoma gene is kept in an active form. And it's kept in an active form because it is hypophosphorylated. Remember that, okay? When the retinoblastoma gene becomes hyperphosphorylated, it becomes inactivated, and that is going to lift this brake from the cell cycle, allowing for a transient movement of the cell cycle into cell division, okay? How does the retinoblastoma genes becomes hyperphosphorylated? The retinoblastoma gene becomes hyperphosphorylated as a result of the actions of the cyclins and their enzymes, cyclin-dependent kinases. The complexes that is actually the cyclins and cyclin-dependent kinases have proteolytic cleaving activity. And what they are going to do is that they are going to add phosphorus to the retinoblastoma gene when they receive a growth hormonal signal. All right, so when they do this, they are going to add phosphorus to the retinoblastoma gene, rendering it inactive and allowing for the cell cycle to move, because this is the signal they receive, correct? Do you guys agree with that? Are you following me, or did I lose you somewhere? Following me, good. All right, so this is what you call the second hierarchy of control. Now, there is even a third hierarchy of control. That's when you go from the cyclins and the cyclin-dependent kinases into the cyclin-dependent kinases inhibitors. So that is going to ensure that this process is transient. So they will come down and they are going to knock down actually the cyclins and cyclin-dependent kinases complexes to ensure that the retinoblastoma gene is going to be, again, hypophosphorylated and is going to take it back to its active form, okay, to ensure the lock of the cell cycle. Now, what will happen if you have a permanent activation? If you have a permanent inactivation, a mutation that result in a permanent inactivation of the retinoblastoma gene, what will happen to the cell cycle? The cell cycle will keep moving, right? So if there is a mutation that is resulting in a permanent inactivation of that gene, meaning that gene is hyperphosphorylated all the time, the end result is going to be putting that, lifting the brake right here and allowing the cell cycle to move in a fast way, allowing for possible mutation to happen and check, which at one point in time may actually end up causing neoplastic transformation, okay? Now, what will happen if you have a cyclin and cyclin-dependent kinases activating mutation? The same exact thing, right? Because they are going to put the retinoblastoma gene into a inactive form permanently, right? And the result of that is going to be the likelihood of mutation happening and the likelihood that actually the neoplastic transformation, occurring at one point in time. What happens if you have inactivating mutation of the CDK inhibitors? The result of that is going to be that, this movement is going to not be countered by the CDK inhibitors, creating a permanent inactivation of the retinoblastoma gene, and the result of that is going to be still actually introduction of mutation that may become translatable into a tumor formation. Okay, so again, there are different levels of control. Why do you think you have different level of controls in normal condition in this mechanism? Because it's what? Exactly. Excellent answer. It is important. This is why you see in a lot of actually the important mechanism in the cell that they have what you call redundant mechanisms. So if the mechanism one failed, there is a second one that is going to kick in. The second one failed. There is a third one that is going to kick in to bring everything back to normal. Okay, and that's exactly what you find here. So if one fails, there is one above it that is going to take over, and so on and so forth. So at the end of the day, you have those actually tumor suppressor genes here, and the p53 also, the guardian of the genome. So you call the retinoblastoma gene the guardian of the cell cycle, whereas the p53, it is the guardian of the genome. Now, why are we calling, to go back a little bit, why are we calling these actually protein cyclins? You're calling it cyclins because of the cyclic nature of the production and the degradation of those proteins. So think about the cell cycle as a relay race. You know what a relay race is, right? Relay race, where someone is carrying the mantle, right? They run a little bit, and then they pass the mantle to someone else who will run a little bit, and so on and so forth. That's exactly what happened with cyclins. So cyclins are going to be produced in one cycle. Let's say the G1. Let's say that it is the cyclin D, okay? And then it is going to be degraded for a second cyclin to appear, from scratch, the cyclin A that is being made, and then take over, the S phase, and so on and so forth, okay? Then cyclin B, and there's a long list of cyclins that are there in order to ensure actually the process of, of the integrity of the cell cycle, okay? So it is due to the, to the production and degradation cycles of those proteins. That's why you call them cyclins. All right, so this is actually in a nutshell what happened here. I don't think it is hard, is it? Straightforward stuff, right? So any kind of mutations that is going to render the retinoblastoma gene inactive is going to do this trick, correct? Any kind of activating mutations of the cyclin-dependent kinases is going to do the same, right? And any kind of inactivating mutation of the inhibitors will do the same exact thing. All right, so we did talk about actually how how the retinoblastoma gene is going to be inherited. Usually it's either actually as a result of a germline inheritance, germline mutation of one of the alleles that's going to be followed later in life by somatic inheritance, or actually somatic inheritance later in life, for both alleles at the same time. Now, retinoblastoma is expressed in multiple tissues in the body. As a result of that, when it is, inactively mutated, the result of that is going to be several kind of, tumors that may arise from this process. Retinoblastoma is, could arise from this process. Breast cancer, colon cancer, and osteogenic sarcoma may actually arise from this process of inactivating mutation of the retinoblastoma gene. All right, so this is the, how it's becoming inherited. How does it come to happen? Either inheritance of one allele followed by a mutation of the other allele later in life, or both alleles becoming inactivated later in life. All right, here is actually another thing regarding the retinoblastoma gene. So to go deeper actually on how the retinoblastoma gene function, you will see that actually the retinoblastoma gene is active here. It is in the active hypophosphorylated form. The reason for this is that actually you have only 2 phosphorus molecules here. By doing this, actually the retinoblastoma gene has a a winged shape. This wing is a closed kind of wing, as you can see here, correct? And this closure of the wing is important. Why? Because it is keeping the E2F transcription factor bound to this gene, okay? It is locking it in. It is locking it from the joining the genomic sequence at the E2F site, because once the E2F complex joins the DNA sequence at the E2F site, that is going to result in the making of the S phase genes, and that is going to result in moving of the cell cycle from the G1 to the S phase and movement of the cell cycle towards cell replication. Now, what's going to happen, in normal conditions, when there is a growth signal that is coming to the cell in the form of a growth factor, growth hormone, growth factor, the epidermal growth factor, the platelet-derived growth factor, it is going to activate the cyclin D and the cyclin-dependent kinases complexes. Those are going to actually hyperphosphorylate the retinoblastoma gene. adding more phosphorus molecules to the retinoblastoma gene. The result of that is this actually closed ring, if you will, closed wing, if you will, going to open up, as you can see here. What happens to the A2F? The A2F goes free and find its way back into the genomic sequence at the A2F site, making the S phase genes, allowing for the cell cycle to move in that direction. Okay. What happens if you actually keep the retinoblastoma gene in its inactive hyperphosphorylated form as a result of a mutation of that gene? There's going to be permanent activation of the A2F site with the A2F, because the A2F is no longer going to be locked by the retinoblastoma gene, and that's going to result in actually permanent movement of the cell cycle, resulting in permanent division of cells, giving rise to tumorous formation. Okay, so that's actually what is going to happen if you have activating mutation of the cyclins and cyclin-dependent kinases. The same exact thing, because it will keep actually taking the normal retinoblastoma gene and making it inactive by hyperphosphorylation, right? How about if you have actually inactivating mutation of the CDK inhibitors, which will ensure that once the cell moves in that direction in normal condition, it will kick in right away in order to reverse that process and take the retinoblastoma gene into its hypophosphorylated active form back again in normal condition. If you have this is gone or this is mutated, then the result is going to be that this process will continue unabated, resulting in a tumorous formation against several kind of lesions that will result in a tumor formation. One of them, to recap it, is going to be inactivating mutation of the retinoblastoma gene, inactivating mutation of the retinoblastoma gene, resulting in hyperphosphorylation of this gene, activating mutation of the cyclins and cyclin-dependent kinases, and inactivating mutation of the CDK inhibitors. Is that clear? Further. Right. So let's go back to normal again, right? Normal from abnormal, right? So you start from normal. Normal is, this E2F is locked in this gene, right? It is locked. It cannot go anywhere. Now, what's going to happen is that actually when there is a signal, the signal will come and will activate the cyclins. It goes to the cyclins and cyclin-dependent kinases, the cyclin D usually. And cyclin D is going to actually inactivate this gene by adding more phosphorus to it. And it inactivated, why? Because the gene is no longer doing its function, which is to lock the E2F, right? As a result of that, the E2F will be released, right? And the E2F will find its way into the genomic sequence and will be making this, phase genes, allowing for the cell cycle to move only transiently. Why transiently? Because the CDK inhibitors immediately are going to kick in to knock down this and take the hyperphosphorylated retinoblastoma back to its hypophosphorylated active form. Okay. Now, what happens if you have an inactivating mutation resulting in a permanent hyperphosphorylation of the retinoblastoma gene? That means this E2F is free to do whatever it wills, and the cell cycle will be moving, unabated. Correct. This is one. Two. What if you have activating mutation of the cyclin D and cyclin-dependent kinases? Same exact thing. What if you have inactivating mutation? There will be no going back to the hypophosphorylated retinoblastoma active form of the gene, and all of them are going to result in a tumorous formation. Okay? All right, let's move on. Okay, so the result is going to be here, right there. This is a retinoblastoma filling actually the eyeball of this patient. Okay, that's going to result, if it comes in, with birth, that's going to result in what is known as the white reflex sign. Here are examples actually of tumor suppressor genes. Again, I don't really, like to ask you, a listing. I don't like to do that. This will be too mean. Yeah, I'm mean, but not that mean. So I want you just to know it actually so that you get oriented to it. There is a long list of tumor suppressor genes in different tissues in the body. These are just examples of those tumor suppressor genes in specific tissues. All right. So now Let's talk about evasion of cell death. How does this cancer cell evade cell death? So let's talk about actually the cell death first. You guys have taken that, when we talked about, the first part of this series. In this case, actually, there are two pathways, right? There is the extrinsic pathway, and then there is the intrinsic pathway. Extrinsic pathway happen actually coming from the outside in. Usually, one of the ways for that to happen is through the death receptor and the death receptor ligand. That's going to be in the form of, sorry. All right, so death receptors and death receptors ligand. What are these? These are actually the CD95, which is part of the TNF family of receptors, the tumor necrosis factor family of receptors, also known as the FAS and the FAS ligand. When the two actually are going to join in, when the cell reaches a point that it has to die, what's going to happen is that the FAS-L will combine, with the, allow me actually to do that because there's a couple of things. Good. You can still, for those of you at home, could you still see the picture or is it too small now? Any answer? Is there anybody listening? Oh, there's 177. So
it's a bit too small.
All right, so let me just the reason for this is there is a couple of acronyms and I hate to memorize. You guys have to memorize it. I don't. All right, let's talk about this. Okay, so so there is actually this, this FAS ligand, this receptor ligand, if you will, that is going to come to that cell, telling the cell that it is time to go. The way it will do this is by combining with the death receptor, that is the CD95, again, a TNF family of receptor, one of the TNF family of receptor. When that happened, when this connection between the ligand and the receptor happened, there will be trimerization of the receptor and trimerization of the cytoplasmic domains of this receptor. That is going to recruit a special form of protein inside the cell, a special protein known as the FAD. The FAD itself is going to become part of this domains of the cell receptors, and the FAD is going to recruit the procaspase 8. So now the FAD, the trimeric domains of the site of the death receptor, and the procaspase 8 is what you call the DISC, the death-induced signaling complex. This DISC is going to act on cleaving the procaspase 8, resulting in the formation of caspase 8. And once that happens, the rest is history. Why? Because caspase 8 will go on its way to activate the caspase 3, and caspase 3 will start the process of dismantling the cell one piece at a time in a very organized way, in the apoptotic way, right? So for this is one of the ways for actually death to happen to the cell. Another way for that to happen also from the outside is through actually radiations or chemicals or viral infections. If you guys recall that actually great chart from the first part of the lectures that I've given you, if you still recall that chart, that's really going to be very helpful. All right, so in this case, you will see that whether radiation, chemicals, or viral, the viral infection that is going to probably be related to granzyme B and the porine, in this case, you will see a form of a DNA damage that is going to actually, has or elicit a p53 response. The p53 will work on increasing the backs and the back, which are pro-apoptotic molecules, pro-apoptotic genes and pro-apoptotic proteins when they get translated. And the backs in the back, what will they do? They are going to catapult themselves into the mitochondrial membrane, allowing for the release of the cytochrome C into the cytosol. The cytochrome C is going to go into the cytosol and is going to, with the help of the apoptotic protease activating factor 1, the APAF1, are going to activate the caspase 9. The caspase 9 will activate the caspase 3, and the rest is history again. Okay, now in the process of doing so, there are actually, you could see that there are some connections between the extrinsic and the intrinsic pathway through, for example, the BID. The BID is one of the BH3 proteins. What are the BH3 proteins? We have talked about this before. You guys recall from the first part, or is it distant memory for you now? So BH3 proteins are proteins that will ensure the balance between the pro-apoptotic factors versus the anti-apoptotic factors. So what are these, what are these proteins? The BAD, the BID, and the POMA, are some of those proteins. What's going to happen is that, let's say that, there is, there is a cell, there is a nuclear damage. The BH3 in this case are going to actually increase in amount so much that they are going to overwhelm the BCL2 and the BCLXL, which are the anti-apoptotic mechanism. So that is going to allow the backs and back to have a field day with the mitochondrial membrane, catapulting themselves into the mitochondrial membrane and kickstarting the process of apoptosis. So, there are a couple of ways for that, to happen, for the death to happen. Now, the tumor cell have also its very unique way, very, what you call creative way, really, of dealing of, not making sure that cell death does not happen. How does it do that? For example, it will actually downregulate its CD95 on its surface. So you have less of the CD95, you have less of the death receptor. So as a result of that, all the signaling may not happen as a result of this fact. When the cell, is having less of the death receptor, it is simply telling the ligand, go away. I'm not interested in dying, And the signal that is happening through this process, this exogenous process, is not going to happen because you have less of the CD95 receptor. Now, another way for that to happen is by actually introducing a special kind of protein, upregulating special form of protein known as Fleiss protein. The Fleiss protein will come and is going to join up, combine with the DISC, the death-induced signaling complex, system, if you will, and it's going to knock it down. That is going to result in interruption of the death signal, correct? Because it will no longer converge on the caspase 8 and from it into, the caspase 3. So another way for that to happen. The third way for it to happen actually is by reducing, it will actually increase the resistance of the mitochondrial membrane, reducing the egress, reducing the exit of the cytochrome C. How does it do that? By simply overexpressing, especially the BCL2. When it increases the BCL2, the process is going to tilt towards anti-apoptosis. We will see how that comes to happen in the next slide. How about actually if it goes and will reduce the level of the backs? So it may actually go after the backs and back, reducing their level. Those are the pro-apoptotic genes. The same exact process may happen. And finally, actually, by increasing a certain molecules in the cytoplasm known as inhibitors of apoptosis, the IAP, they are going to upregulate the IAP. By upregulating the IAP will go after the caspase 9, cleaving the caspase 9. So again, the death signals is not going to continue to the caspase 3, and the cell will live on. All right. So there is again, there are multiple ways for death of the cell to happen, again in a redundant fashion, and the tumor cell also have redundant mechanism to deal with this cell death in order to ensure its survival. Okay. Several mechanisms, we have talked about them right here. All right, so how does actually this happen in a special tumor known as B-cell follicular lymphoma? In the B-cell follicular lymphoma, we see that chromosome 14 also figures prominently. The translocation that happened in those tumors, in about 80% of those tumors, is the translocation 14-18. If you recall, 14 harbors the immunoglobulin heavy chain active promoter. Now, on the chromosome 18, there is actually, the BCL2 gene carried on chromosome 18. When there is a balanced translocation that will take this BCL2 and put it in chromosome 14 under the role, if you will, of the immunoglobulin heavy, heavy promoter, heavy chain promoter, the PCL2 is going to be overexpressed. What will that do to the cell? It's going to increase the resistance of the mitochondrial membrane and decreasing the egress or decreasing the exit of cytochrome C, ensuring cell survival. And those type of tumors, are going to result in making the cell less likely. Of course, and if everything dies, but this is going to ensure the increased longevity of that cell, decrease cell death. Okay. So, in your opinion, what kind of tumor will that be? Is it going to be a high-grade tumor or a low-grade tumor? No. High-grade tumor is a tumor that is dividing like there is no tomorrow, right? Living the party life, if you will, dividing fast, giving rise to a tumor fast, and then succumbing and dying fast, right? Now, the low-grade tumors are the tumors that will result from this very process, which is less likely of the tumor cell to die, because this cell is not dividing fast. Simply, this cell is refusing to die, correct? So this cell is there refusing to die, the nearby cell refusing to die. Eventually, all these cells actually carry the same translocation. That's a definition of tumor last time I checked. And the result of that is going to be the formation of a low-grade tumor. Which is easier to treat, a low-grade tumor or a high-grade tumor? Which is easier?
Low-grade tumor, because there is no production of new cells.
Right. Well, there's increased longevity, right? Right. Actually, but it's a harder tumor to treat because you don't have really anything that is going to take care of this, refusal to death, refusal of death, if you will. Whereas, for the rapidly dividing tumor, we have anti-proliferative mechanism, anti-proliferative drugs. We have drugs that target cells that are, rapidly dividing cells. But you don't have, any drugs that will go, at least, in general, that will go after a cell that is refusing to die. Okay. So it is the high-grade tumor that is, of course, it is more deadly tumors because it may kill the patient in a very short period of time because it's growing very fast. But if you catch the patient early on and you hit him with those anti-proliferative medication, if you will, then you're going to be, anti-mitotic medications, anti-cellular medication. You are able to, to give that patient a chance. With low-grade tumor, it's what you call, again, like life gives something and takes something back. So you will see that low-grade tumor, it's not going to kill the patient in a short period of time because it's a low-grade tumor. It's a slowly, growing tumor, right? So the result of that, and usually it happens also in later life. So you will see that those patients will live almost to, their predicted, lifespan, okay? So because it happens later in life and they cannot really take any form of chemotherapy, at the end of the day, you're not going to really give them anything. You're simply going to treat the symptoms of the disease rather than the disease itself because you have nothing to treat the disease with, okay? So this is what happened in follicular lymphoma. You have a question? Sorry? Yeah. Yes, thank you very much. All right. Okay, here's an example of that. Again, like, if you have any issue with pathology, believe it or not, your problem will not really be most likely pathology. It will be something that came before pathology, either biochemistry or histology or embryology. So always check on that. Pathology is the weak link, if you will, in all of this. Now, if you look at this is what a normal lymph node, look like. If you look at this cell, compare it to follicular lymphoma, I put these two pictures for you. So you will see that the follicles, in a normal lymph node are of different sizes. This variety is very important actually in a lymph node. So different sizes. You don't see any monomorphity, if you will. It's not monomorphic kind of appearance, right? They have different sizes and shapes. If you look at them, also there is, one part of it is actually one part of it is dark, the other part is light. That's actually what you call polarity when it comes to follicles. This is similar to what we have seen in the polarity of the epithelium, if you guys recall, that what's head is head, what's tail is tail, whereas in cancer, you will see a loss of cell polarity, right? Here in the normal lymph node, you see also polarity. One area is dark, and the second half of that, follicle is light. That's also, the equivalent of polarity. All right, if you look, there are a lot of space, paracortical space, if you will, between, in the cortex, between the different follicles, a lot of space between the follicles. You look, you have a medulla here, right? There is a medullary region as well. Now, when you look at the fat, and the fat is clear of lymph nodes, it's very well circumscribed, if you could agree with that with me. Now, if you compare this to this right here, if you look here, you will see that the follicles are in the fat. So that's actually in a way telling you that the follicles are invading the fat, telling you that the process at hand is really a neoplastic process, a malignant process. Two, look at the size of the follicles. Doesn't it look almost the same all? Do you agree with that? So that's actually, again, monomorphity of the follicles, another indication of neoplastic, transformation. You look at the amount of paracortical space in the cortex. Is there any space? And really no, because the follicles are back to back, another actually indication of a malignant transformation. You look at the mirror image. Do you have a mirror image similar to this? Well, dark and then light? No, you don't. So there is, again, loss of mirror image, which is the equivalent of loss of polarity in the epithelium that you guys took before, okay? And then you look at the medulla, and you will see that the medulla is no more. There was a medulla here before, it's no longer here. The reason for this, there is effacement of the lymph node surface with this neoplastic process. All of those are features, actually, of malignant transformation of the lymph node. How do you think a patient like this is going to present to you? So because it's a low-grade tumor, those low-grade tumors usually affect multiple lymph nodes at the same time. So those patients are going to present with symmetrical enlargement of the axillary lymph node, of the inguinal lymph node, of the cervical lymph node. All right, so this is what you see in a low-grade lymphoma, such as follicular lymphoma. What do you see in high-grade lymphoma? If it's a lymphoma, that is a different lymphoma, a different patient that is coming with a high-grade lymphoma. In that case, instead of this symmetrical kind of enlargement of all lymph node groups, you're going to be seeing a dominant group that is going to take over and grow. So you will see the right axilla having a very large mass and nothing else anywhere else, okay? So again, there's some clinical kind of connotation to this. Same picture to show you actually the difference that we talked about. All right, do you need me to go over the same here, or did you guys get it? You got it, right? All right, limitless replicative potential. Again, the tumor cell, theoretically speaking, could live forever, really. Theoretically, of course, that's not going to happen. Why? Because the tumor cell, like I told you, it's an abnormal cell, is accumulating insults as time goes by. Its chromatin is very fragile. And as a result of that, there is a propensity to develop even more mutations. At one point in time, those mutations that this cell is aggregating or accumulating will simply kill it, because there is no way to actually bypass those mutations. It's going to be what we call a rate limiting process that will kill that cell eventually. But in theory, it actually has the ability to live forever. How does it do that? It does that actually by working on the telomere. The telomere is a terminal part of the genome that is sequentially shortened with each subsequent division. The tumor cell will come and will make sure that this shortening is not happening. It will add more genetic material to this telomere to ensure that it is not shortening. The reason why is that important, because at one point in time, when the telomere becomes very short, you will see that this telomere becomes a small, short double-stranded piece of DNA that is going to be recognized by the p53 as such, and the p53 will come, take the cell by hand, and tell it, thank you very much, your job has been done. It's now for you to do one of two things: either go through the process of apoptosis and die, or actually it will put it in a non-replicative state known as senescence, okay? So the tumor cells know that, and for it to do what it does, actually it goes and making sure that this telomere is not reaching that stage. By adding more, elements to it, by adding more, genetic elements to it, making sure that it is long, it is not sequentially shortened with every subsequent division. Development of sustained angiogenesis. As I mentioned to you, this tumor mass is growing. Areas within the tumor mass are going to undergo hypoxia. Those areas are going to have increased, expression of the hypoxia-induced factor, HIF-1 alpha. this HIF-1 alpha is going to recruit the VEGF, and VEGF will take care of business by actually inviting endothelial cells and also stromal cells to build this actually neoangiogenesis vessels. Now, what the tumor cell is going to do, so this is what happened. A tumor cell growing, HIF-1 alpha, recruiting VEGF. Then the VHL, if the VHL is intact, it will counteract this process, because VHL, the von Hippel-Lindau gene, is a tumor suppressor gene in the sense that it will oppose this process of HIF-1 alpha and VEGF. So what does the tumor cell do? The tumor cell will go and mutate the VHL, and that is going to allow neoangiogenesis to happen for those tumor cells. So for all practical purposes, this is absolutely not a random process. It is a well-designed process, if you ask me. All right, ability to invade and metastasize. How does that happen? We did actually talk about the different levels. So the different levels of the clonal expansion, starting with increased number of cells, and then actually cleaving through the basement membrane, then cleaving through the extracellular matrix, reaching the blood, cleaving through the blood vessels. So it does actually, get itself intravasate, if you will, a nice word to describe this process, into the blood vessels, and it's going to actually cover itself with blood cells. By doing this, it's shielding itself from the immune system. It's going to go with the flow. So as a result of that, where actually the tumor cells end up in has a lot to do with the lymphatic drainage, with the arterial, blood supply. Has a lot to do also with with the receptors that are present on those tumor cells, and also in the microenvironment of the site where it is going to get lodged. Eventually, it's going to get lodged at one point in time, and then it's going to extravasate. It's going to go out of the blood vessels, and it's going to try to establish actually a neoangiogenesis network in that region, establishing a satellite of the tumor mass. Not all the tumor cells are going to actually metastasize. If you recall, we talked about the subclones, right? The subclones that beat the odds. It is going to be those subclones that are able to do it. Usually the most aggressive subclone within the tumor mass. The subclone that is able to invade, cleave basement membrane, cleave ECM, go through the blood, deal with the immune system somehow, reaching the blood, extravasation, and the ability to make new blood vessels. All right, so how does it do that? Let's start with the first process. So the cells are sitting side by side. As long as they are side by side, everything is actually limited by the basement membrane. So the first step that the tumor cell will do is going to detach itself from other tumor cells. How does it do that? It does that actually through downregulation of the adherence junction and the tight junction protein, and that is going to make those cells free. That's number one. Once they are free, then the next step will come, and that is going to be in the form of fixing themselves on the laminin of the basement membrane and also of the fibronectin of the ECM. And at the same time, they started actually to make the MMPs, the matrix metalloproteinases, also known as the collagenases. Why? To take care of the type 4 collagen. So they make exactly the enzyme that is needed to cleave through the basement membrane and through the ECM. That should tell you that it is not really a random process. Now, what does it do for the laminin? It's going actually to attach to the laminin. Why? As you can see here, it did attach to the laminin. It does have laminin receptor and have also fibronectin receptor. Why? Like I told you, it is using it as a platform, as a springboard, if you will. That before you jump, before you take your next step, you want to make sure actually about your footing in the first step. That's exactly what it does here. And then it's going to be actually releasing this collagenases or MMPs. The collagenases will take care of the type 4 collagen in the basement membrane and in the ECM. The end result is going to be cleavage of the basement membrane. Now it is in the ECM. In the ECM, it's going to, through its fibronectin receptor, bind to it. And at the same time, it will start actually to create or to make cytokines. Those cytokines are going to stimulate locomotion. If you look at those cytokine loop, if you will, the autocrine motility factor loop, what does it look to you like? First, this actually cytokines are going to be helping the cell to take a very, what you call, infiltrative shape. If you look at this cell, the cell has become pointy, correct? That is actually one of the functions of those cytokines. The second thing is to create what looks like wheels, really. As a result of this loop is going to propel the cell further down in the ECM. Now, at the same time, the cell is making actually proteases. The proteases will take care of the ECM, the extracellular matrix, digesting it and allowing for a road for that cell to be made so that it will go through the ECM, eventually finding its way into the blood and then finding a satellite position somewhere away from the original site. Where does it end up in, as I mentioned to you, is going to be related to vascular, arterial and venous supply, lymphatic drainage, interaction of tumors with organ-specific receptors, and the microenvironment of the organ or site. Reprogramming of energy metabolism. As I mentioned to you, the cell, even though it is a highly sophisticated cell, but it is still an abnormal cell. And a lot of the normal functions are no longer actually happening. One of them is going to be the nucleus that is busted. The second one will be the mitochondria itself that is busted. As a result of that, so there's no crosstalk between the mitochondria and the nucleus, and that's very important for the oxidative phosphorylation. The mitochondria itself is abnormal. The end result is going to be that oxidative phosphorylation could not happen in these cells. So those cells could not use oxidative phosphorylation to produce energy. So what do? They go and draw back actually from their embryologic life, a special, phenomenon known as the Warburg effect, by breaking down the glucose and actually getting this small amount of ATP molecules in the form of 2 ATP molecules. But that's all they need actually, for them to divide. That's, exactly what the cells in the embryo do. At that stage, the only thing that is important is simply increasing the number, spreading, the number of cells, increasing the number of cells. This is exactly what is needed right here too. So those cells will do the same exact thing. All right, so doubling up, using the glucose to actually draw back, to draw the energy from it. Now, genomic instability, as I mentioned to you, there are those DNA repair enzymes. Let's say that a cell is actually get exposed to ionizing radiation. The cell will be damaged. The first thing is not really going to be killing those cells. The DNA repair enzymes are going to kick in, and if the insult is too severe for them to correct, they are going to activate the p53. The p53 will come and put the cell in one of two conditions, either apoptosis or non-replicative state known as the senescence. Now, there are people who actually are born with the DNA repair enzymes deficiencies or DNA repair enzyme mutations. The result of that is going to be actually development of cancer at a much higher rate than the rest of the population. Example of that is the NHP-CC, the hereditary non-polyposis colon cancer syndrome, and the pseudoderma pigmentosum. Finally, inflammation. As I mentioned to you, inflammation was thought to be a good thing, that it is going to be helping the body against tumor formation. Now we know it's a double-edged sword. Why is that the case? Because once actually there is a chronic inflammatory state have set in and have actually, have been, working on that patient, the cell cycle of those cells affected by the inflammation is going to increase, which is going to allow for the introduction of mutations that will become, unchecked, because there is a threshold at which those tumor suppressor genes that are supervising this process could do their job. Once you increase, the cell cycle speed, that's going to be actually non-existent. And the result is going to be the likelihood of development of cancer. Example of that, patients with ulcerative colitis. Ulcerative colitis is an inflammatory condition, right, affecting the colon. In 10 to 20 years, those patients are going to be developing colon cancer. Why? Because of the chronic inflammatory conditions that was happening to them during that period of time. Now, at the same time, actually, inflammation is going to result in the invitation of inflammatory cells to the site of action. If the inflammatory cells are actually neutrophils or macrophages, those cells use actually, use the free radicals in order to neutralize, pathogens, in order to deal actually with, damaged tissue. And in the process of doing so, those free radicals are going to act again on the tissue, resulting in, corruption of the genomic material of those cells and the possibility of neoplastic transformation again. This is it. All right. Any questions? Did you guys get it? This is probably the hardest part. I think it is simplified now for you. Do you agree with that? I don't think it is that, that complicated anymore. All right. So let's see. Where's my grade T8? Any questions?
Does the doctor have any advice for exams?
Yes. Yeah, the exams will be straightforward. It will not be impossible. I can tell you that. Okay. My suggestion, like, when it comes to exam, like I said before, usually pathology is really not the weak link in the sense it's weak. It's absolutely not weak. It is really the bread and butter of step one. For your information, you do pathology, you get about 60% of what you get on step one exam, the USMLE step one. So, but it is like, if you compare it to, for example, to micro and pharma and immuno, those are tougher because they need far more memorization. So you need to dedicate more for them, if you ask me. So I will definitely do pathology for sure. I will not skip it, absolutely not. But I will also like make sure that I divide my time equally, for the, or at least, give enough time for the other, topics such as micro and pharma and immuno, which in my opinion are going to be harder for you. Is that correct? Do you guys feel that way? Yeah. So I will divide my time in a reasonable way. How about that? This is a political one. Yeah. What else?
Now, can you go over slide 38?
38. 38. Let's see, what is that? Yeah. So 38, again, what you have here is that, first, not all the tumor cells are going to invade. So if you recall, actually, the first step in the carcinogenesis is going to be transformation, full thickness transformation of the epithelium. That's going to be limited by the basement membrane. Then a subclone of this carcinoma in situ will have what it takes in order to cleave through the basement membrane first, and then the ECM, the extracellular matrix, and then actually intravasate itself into the blood vessels, forming a tumor embolus on its way, to forming, to actually getting, lodged in an area where it will extravasate and form a satellite tumor metastasis in that region. Okay. Simple as that. Yeah.
Doctor, do they need to know the molecular biology details, like the different cycles and steps?
The cycles. No, again, like, I want you to know the process. I want you to know the process. So for me, what you need to know in this, right? What you need to know in this, the hierarchical, process, the retinoblastoma, what does it do? And then the control over it by the cyclin Ds and cyclin dependent kinases, and then the negative control by the CDKIs, and then what happened to mutation in each one of them. I will not ask you what P21 does, God forbid, or P27 does. All the concept really.
Okay. VHL tumor suppressor can it be used?
What is it? Which one? I'm sorry.
VHL.
PHL.
VHL.
VHL. Right. So. Yeah. Right. So, there is a tumor mass that is growing fast. If it's a rapidly dividing tumor, there will be a region within the tumor mass that is going to undergo hypoxia. Those regions are the cells of those regions are going to upregulate a special gene known as HIF1 alpha, hypoxia-induced factor 1 alpha. The hypoxia-induced factor 1 alpha is going to work on the VEGF. It's going to increase the transcription, of the VEGF, the vascular endothelial growth factor, which is going to recruit endothelial cells and the stromal cells to that site. And that's going to set actually the stage for the new, angiogenesis. So in that case, the VHL works as the von Hippel-Lindau, gene is going to act as a tumor suppressor gene, because it's going to actually counteract the HIF-1 alpha, and the result of that is going to be actually no neoangiogenesis getting formed. So what the tumor cells do is that they go after the VHL, and that is going to result in mutation of that gene, which will allow the HIF-1 alpha to rule and to recruit the VEGF and to set in the neoangiogenesis.
Can you please repeat the low and high grade tumor, like the
Right.
importance of them?
Right. So a high grade tumor is a tumor that is resulting from rapid, cell proliferation. So the result of that is going to be a tumor mass that will form very quickly. Okay, very quickly, and it may kill the patient because it will have very short kind of lifespan really. And that's going to be the rapid dividing tumor. Now there are other tumors that where the tumor is not really resulting from the rapid division of cells. It is simply resulting from the fact that the tumor cells are not dying. So those are tumors that where the cell is able to evade apoptosis. So example of that is going to be the follicular lymphoma. With follicular lymphoma, you're seeing cells that are not actually dying. So the tumor mass is going to grow, but it's going to grow very slowly, and it's going to take really, some infinite time to do that. So that's what is going to result in what is known as a low-grade tumor. So it's a tumor mass that most likely is not going to, kill the patient right away. It's going to take, significant amount of time for it to do that, and usually it happens in the older population. So. And you don't really have anything to treat it with. So most of the time, you're going to leave it on its own, really. You're going to treat the symptoms of the disease rather than, you go after the cells itself.
Thank you. Doctor, can you please repeat the mechanisms that tumor cells use to escape apoptosis? Just briefly.
All right. Right. So, again, we talked about the normal apoptosis. So comes the abnormal apoptosis, either, by simply down-regulating the DES receptors. So you have less of the CD95, which means, you will have less likelihood of the ligand and the receptors, joining up, and then less likely for the signal to be transmitted into the cell, telling the cell that your time is up. So that's one way for that to happen. Two, recruitment of a special protein in the cytoplasm known as the FLICE protein. The FLICE protein will come and is going to actually knock down, destroy the the DES-induced signaling complex. That is going to interrupt the DES signal, and as a result of that, there will be no apoptosis, at least from the extrinsic pathway. How about actually if you have increased resistance to the mitochondrial membrane? And that is going to happen by upregulating the BCL2, or actually by decreasing the BAX-MBAC, okay, all right, or by mutating the p53. The p53 is the gene that is entrusted in taking care of the genomic, actually the whole genome, the patency of the whole genome. You don't have a p53 functional, the result of that is going to be that the intrinsic pathway is going to be affected, because there will be no more signals coming to the nucleus, coming to the mitochondria, telling the mitochondria that the cell is no good and it has to go. All right. There is also the likelihood that that there is upregulation of the inhibitors of apoptosis. These are molecules that are present in the cytoplasm, and those molecules are there actually to ensure they are normal. They are present in normal conditions, and they are in direct balance with the normal apoptotic process. If you upregulate the IAP, they are going to find their way into the caspase 9, leaving caspase 9, interrupting the intrinsic flow of the apoptotic process.
Doctor, shouldn't it, to escape from apoptosis, it should increase the BCL2, not reduce it?
This is what I said, that it will increase the BCL2, upregulating the BCL2, and that's going to result in increased resistance to the mitochondrial membrane, allowing less cytochrome C to escape. Okay? Anything else? All right, go ahead.
I want to ask about the HIF factor. Is it secreting as well from normal hypoxic cell?
Well, yes, but not as much as you will see in the. Yeah, it's a gene that is there, aren't you? it will be upregulated in those extreme conditions. You won't have the same condition in normal cells. Okay. Anything else? Anything else? To ensure, we have a complaint about not paying attention to the. All right. Thank you, guys. Good luck. I hope I will not see you again in a POD. How about that? Is that a good wish? Yes.
Thank you.
Again, no, I want to see you again, but not in POD, in other blocks, if you know what I mean. All right, so I guess you will.